I'm Dr. Deepak Bhatt from Brigham and Women's Hospital and Harvard Medical School. It is a pleasure for me to be here at the 21st Annual World Congress of Heart Disease. I just finished a presentation on controversies in antiplatelet and anticoagulant therapy. In that presentation, I addressed three controversial areas. The first was, what is the optimal duration of dual antiplatelet therapy after acute coronary syndromes? And the bottom line, I concluded, was that in patients at low risk of bleeding, that the optimal duration is greater than 12 months. Of course, the guidelines say to do 12 months and then give a Class 2B recommendation to continue thereafter. And that means it's really up to good physician judgment and individualizing the risks and benefits of a specific patient to make the decision whether to extend, but that in general, in the ACS patient, especially if they're at low risk of bleeding, continuing dual antiplatelet therapy with either clopidogrel or ticagrelor, depending on the patient, does seem appropriate based on the data. The second controversy I addressed was whether to pre-treat with oral ADP receptor antagonists or not in patients who are undergoing catheterization, some of whom have acute coronary syndromes, but even for stable coronary artery disease. And I reviewed the data, which in fact, contrary to what many people believe, if one restricts the analysis to prospective randomized clinical trials addressing the question, actually find no benefit of pretreatment with oral ADP receptor antagonists, but rather find a bleeding hazard. So in general, if a hospital has a quick time to catheterization, I don't mean it just in STEMI, obviously everyone's striving for that, but also in non-STEMI, if that time to treatment is short, then it makes sense, I think, to withhold oral ADP receptor antagonists until the coronary anatomy is defined, and then if they need surgery, then of course they don't get treated, and if they don't need surgery and getting PCI, then they can get treated, and I would say one should consider at least an approach such as intravenous cangrelor, a short-acting intravenous ADP receptor antagonist. The third controversy I addressed was what to do in that really tricky patient who has atrial fibrillation but also has an acute coronary syndrome, likely is also going to get a stent. And the short answer is we don't really know what to do with respect to triple therapy or double antithrombotic therapy, but in general, to try to curtail the duration of double therapy and actually try to make it one anticoagulant plus one antiplatelet, and only in patients at very high ischemic risk and very low bleeding risk in that subset to consider triple therapy, that is two antiplatelets and one anticoagulant. So in general, minimize that duration of triple therapy to no more than 4 to 6 weeks, maybe 0 weeks, and then the double therapy for a period of time, but maybe after a year to even drop to single therapy with the anticoagulant as the Europeans commonly do. The truth is we don't really know what to do with this complex subgroup of patients, but there are 3 large ongoing randomized clinical trials, so in a few years we'll have a clear answer, hopefully.